if you just bear with us a moment, we'll let people in through the meeting room, the waiting room. If you like, you can introduce yourself in the chat, just say hello, and if you've got any specific questions you want to deal with today, leave it in the chat room there. Plenty of you can put the Open Data Save Lives webpage in the chat as well, so people can see. That'll be grand. Please have a look on the webpage. Everything we've done is on there, so all of the sessions have been recorded are there. All of the outputs, the Google documents, the sessions, the blog posts, all the outputs in there. If you've not met before, I'm Paul Connell from ODI Leeds. You can probably tell the ODI Leeds people with their logos and the Open Data Saves Lives backgrounds, so they can all give us a wave. I'm just filling as people join us through the waiting room. The way we run Open Data Saves Lives is we're getting to a format now, so what we do is we've got 2 or 3 interesting talks, some chat, some conversation, people get things off their chest, ask for help, requests, and then we move forward. So today we're talking about tools that people have developed or built or delivered. And we've got 3 friends of ODI Leeds who have been building things. So we've got Dave Tarrant from ODI HQ, I can see there, give us a wave, Dave. He's going to talk about the tools they've been building around skills and development and support to people dealing with data and coded. Paul Clark's there from Beautiful Info, I can see. So either Paul or Marc are going to tell us about the data tools that Beautiful Information have been building down in Kent, how people can get access to them, what to do, that sort of thing. So give us a little quick demo on that. And who is here from MadeTech? Is it?
Hey, it's Jessica.
Jessica. Hi, Jessica. And MadeTech have got a fantastic open source tool that they built and have been developing for a couple of CCGs that they're going to demo and share with us as well. So that's fantastic. And then, as usual, we'll open the floor up to people to ask questions. We can either put them in the chat, or people can just ask us, put your hand up physically, or use the Zoom feature to put your hand up, and we'll deal with it there. My objective with all my video calls now is to try and get them under an hour, so that we all get a bit of time back. So we're aiming to get this finished by 11:45. We've got this now, so we start about 11:03, 11:04, which gives enough people time to join us, and then the target people can just join in as and when they want. So we're still letting people through the waiting room. We're up to about 20 people on the call now. Let me flag up some of the work we're doing. So I don't think you might have seen our work with the Netherlands Embassy and their work. So we're doing something called the Northern Lands Online Conference, Summit, Session, whatever you want to call it. But it's a fully online designed conference running over 2 days in the first week in July. I'm just filling now. So on the Monday, the 6th, and Tuesday the 7th, we'll put a link in the chat in a bit. We've got 4 sessions, 2 hours long, about the work that ODI Leeds is doing. So we've got Open Data Saves Lives, we've got sharing data, we've got a session on mobility in cities, and we've got communication in a socially distanced world. So what we're doing now. So we've got 4 2-hour sessions over those 2 days. And then we've got some interesting tech that we're looking at to how we can recreate the coffee room or the pub or the serendipitous conversations that we all have at conferences and some of the reasons we go there. So we're now at 11:04. And we're going to start. So what I'd like to let's test Dave Tarrant's microphone. If you take yourself off mute, Dave.
1 2 3 4. 1 2 3 4.
Dave's there. Dave's going to talk to us about what they've been doing at ODI HQ have been doing in response to COVID and some of the tools they've built and what we can do to help. And I'll just still for a little bit longer, I'll let some more people in. And Dave, introduce yourself, tell us why you're here, and over to you. Thanks very much.
Are we recording, Paul?
We are recording, yes.
Great, excellent. Okay, just got to check 'cause I can't see the symbol anymore. Anyway, morning everyone. Thank you, Paul, for the intro, and thanks everyone for letting me have a few minutes just to speak about what we're doing at what we have been doing at ODI HQ. I'll share my screen because I've got a few slides that will help walk us through it. You should be able to see that now. Paul, do you want to give me a thumbs up? Or somebody at Leeds to give me a thumbs up? Yeah, great, thanks. So with our project, we got a little bit of funding through Luminate, so I want to talk through what we've been doing with that and how we've been trying to help people. But what I'm going to talk about here is mostly on the link that's on this slide, so the ODI.org/topic/COVID-19, where everything is. I was just going to go through a few of the guides that we've been producing. So when we started the project, the idea of helping out, very similar to ODI Leeds, helping people get access to data to help with decision making during the crisis, and part of the funding we have scope to help people and support organisations to make models, data models and software as open as possible. So those are our three main focuses. We put out a call for interest, people who wanted help, and we had over 100 submissions in the first week to that call. We boiled them down into three main things that people were looking for help with around our expertise. One, publishing guidance and tools. Okay, common theme there. Let's get some data out there. Anonymization, obviously a lot of the data being about people, and the third one being ethics. So what we've done initially with the project is focused around how we can help organisations and people with those three things. So the first one that we started on was to boil down a simple guide to publishing open data in times of crisis. So we've got three key steps in it that Paul and the team, I'm sure, have talked about lots. And to back up that guide, we also did a little bit of work on our Octopub tool. Don't know if people have come across Octopub before. It's a GitHub-based data publishing tool. It's like a front end on GitHub that's purely written for data. Upload data, put a license on it, press go, and it generates you a nice, as you can see here in the bottom right hand corner, a GH Pages kind of web page with the data in it. We've been extremely interested to see who is helping us with that. People might have seen that the TUC have started publishing all the COVID secure check assessments. We're encouraging people to publish the COVID secure check assessments using Octopub. Okay, so if people are interested in that, you can look up COVID secure check and find out how many organisations currently publish assessments, and they're all published via. They're saying that use Octopub. It's a nice, easy to use tool. So that one, actually we found out about that, I think, on Twitter. So that was pleasing that someone had come across it and using a tool. Always nice when that happens. So we did a little bit of maintenance to Octopub to make sure that it's reliable service. Again, we haven't used it for a few years, but these kind of simple tools during a crisis. So if you're interested, it's octopub.io for that one. So the guide alongside a tool. Another project we worked with that came through this process was Track Together, which is one of the symptom trackers. This is again something that's been very hot during in COVID. A lot of these are about, and the NHSX has started saying about getting a lot of data together from them. I'll talk about that in a minute. But Track Together contacted us as they wanted some help with things like anonymising and publishing the data openly. So again, we kind of pointed them to the guide through. They didn't quite use Octopub for it, but they did pull the data from GitHub, and we also helped them do some bits around anonymising the data. So on the back of that, we also produced a 7-step little guide for people, practical guide on anonymising data. This one's quite interesting because what we did with it, we did it practically to give people an example that's relevant to COVID-19. So we backwards engineered the NHS 111999 data to put the personal data back in it. So we made up some, people from Harry Potter, wizard names, etc. If you like that kind of thing, and put that kind of personal data back in the 111999 data, and then demonstrated how you go about anonymising that to produce the data set that they are publishing. So that's how we kind of made that relevant to the current situation. So if people are interested in that, it includes a practical walkthrough that goes through these 7 steps for a hypothetical but close to the actual data set. So there's a guide there, and with the practical example. And in terms of ethics, There's a lot of discussion, and there has been a lot of discussion around these three things and the confusion between them. There's a lot of data about people being collected right now in various different ways, and there's different types of services that people are talking about. The symptom tracker, contact tracer, immunity passport. I'm sure you've all come across these different ones. So one of the first things that we started was to write an explainer for these, and we produced some. Our team produced some great graphics that people can use to help people tell the difference between these, and then alongside that we wrote an explainer that also points towards some of the ethical issues with each of these and the differences between them, because what we've been looking at is what happens long term. A lot of people have been starting to consider that. What happens afterwards? You know, where does this data go? Where's the benefits that come in the long term? Okay, and how do we do that in a way that is ethical? So, you know, our general line, you know, technology can be helpful, but it's important that it's effective, well built, and proportionate. Again, we've seen a lot of emphasis on that over the last couple of weeks with things like the diversity, inclusion, Black Lives Matter, all the rest of this around it. It's got to be, you know, relevant and proportional for everyone. And it's important to do those kind of innovations in the open. So this is where we've been looking at how the ethics canvas can help. And we hope next week to have another guide up that boils down our data ethics canvas. To help people get a grips with what you might need to think about, you know, in times of crisis, how to think about ethics. So hopefully that guide will be up next week. Going forward, we've got a couple of key focuses. Focus one, we're working a lot in the area of best practices for data made available by symptom trackers. There's a lot of talk out there about whether there's a need for standardization, whether there's a need to set, you know, to bring data together to convene it around, you know, some kind of standard, some kind of reusable way. Whereas a lot of others are saying, well, just gather all the data together. So we're kind of having a voice in this area, and I mentioned about the latest news where NHS Digital are partnering up with J-Hub. So this is an interesting development that we didn't necessarily know all about. So we're going to be keeping an eye on that one and hoping to feed into that conversation. Focus 2 that we're going to be looking at is around mobility as we get back to normal. There's been some interesting work by one of the ODI supporters, Geolytics, in this area already, looking at what's now happening as a result of in the UK they've been looking at, but in different countries around as lockdown is lifted, how do we start to use this opportunity to help us understand how to get mobile again, or the restrictions that might need to be in place depending on how we need to potentially live with COVID-19 in the long term. So what kind of services might we need to know about for when things are quieter, when transport is quieter, when it's best to go on certain things. So mobility might be a hugely changing sector. So we're looking at that in terms of, there's a lot of data currently being made available, but a lot of it's got conditions like only during COVID. You know, what happens if we live with COVID? Okay, what happens in that situation? How do we mobilize the data to help us to deal with living with it? So this is our focus 2, and we're doing a lot of research on that at the moment, and there's a lot of week notes as well on the website. So that was, I'm trying to keep Paul on time, so hopefully that was a rapid tour through 3 of the things that we've been doing, helping people publish. Being the first one. We've been doing a lot in the anonymization space, you know, and a lot in the ethics space, with those 2 focuses around symptom tracking and mobility. So if you want to know more, all of this is available on our topic page on the website. So that's the only thing. All the guides, everything is linked there. And again, guide should go with tool. So hopefully they match together. And that's a little update from ODI HQ. Happy to take any questions.
Fantastic, Dave. Thanks very much for that. And we know you've all been working really hard. It's fantastic to have you here. Lots of your team have been on the calls previously, so that's great. And I guess we'll put all of this on the Open Data Saves Lives webpage. We'll put the links to it, and we'd love a little. We're going to record this, but also get a little message from you about how people can do that. I have one request to you. I have been on numerous calls this week where technical people and comms people have been on the same call, and the comms people are all about, yeah, but what if people use our data wrong and they come to the wrong conclusion, or we need to control the message and we need to decide what we're telling people, which is madness. So I would love a session around, or some guidance around, that says if you are more open, you are more trusted. the more data you publish, the better. Ask people what questions they want answering and fix it, rather than trying to have a mad control the message, keep it out of the Daily Mail, rather than trying to help people understand what's going on. Sorry for ranting there, but I've been on the thought that when people get a chainsaw, they get all of the guidance and they have to wear PPE to use it. Data's just like that, which is not, absolutely not. And also the question that the public might come to the wrong conclusion, whatever the wrong conclusion is maybe you don't agree with it, but the data's still the data and it's factual. So if you could take that away and do something to help comms people get off their high horse and stop people understanding what's going on, and save lives, not data, would be a great.
Perhaps I can add a little something for that in terms of the ethics guide that's going to be coming. One of the things that, as part of our data ethics canvas, there are 4 main focus areas that we're boiling it down into: data, impact, process, and comms, communication, engagement. Okay, and as part of that section, we emphasize the point about people often get extremely angry. Here's a question for people on the call. You can put your hand up for this. We'll do an A or a B. Let's find out. Remember when you were a child, right, and you got home late from somebody's house. Yeah. Well, you've got the raise hand. I'll ask it and see how many people raise their hand, right? So you've been out late. You're past the time that your parents said get home by this time. If you're not home by this time, etc., etc., etc. Okay, and you've gone past that time. You got completely lost, and you got home late. Were your parents angry because you're home late, or were they angry because they didn't know you were going to be late? So let's go for the quick raise of hands. Were they angry because you were home late? Or were they angry because you didn't tell them you'd be home late? There you go. Right, communication, right, is the key. Right? If you don't tell people what you're doing, okay, it's not a matter of don't do it, it's a matter of tell people what you're doing. And so communication being the key there in our ethics canvas, saying it's actually, people are more angry when people don't know what's going on. Help them not misuse the data and all these things by being clear about what data is being collected, how it's being used, how other people can use it, how people can get engaged in that conversation. And these kind of open forums are great for that. So hopefully some of that messaging will get through, Paul, in that sort of way, because we need to understand what's the reasons that people get angry, and most of the time it's because they don't know.
Yeah, I'm going to stop. I'll stop ranting, but also it's not people's job to block the data. It's not your job to control the message and tell people what to think. I'd love the ODI to come out and say that a little bit stronger. So I might say it for you, but comms people is not to stop people seeing data and making their own mind up. People are pretty sensible when they get reasonable data, so it's your job to get the data in their hands. But I'll stop ranting now. I would like now, because we're all amongst friends, I'm going to go over to Jessica, who is new to Open Data Saves Lives. We spoke to Luke last week, and it's very great. It's a great pleasure to have you here today. So tell us who you are, where you're from, and why you're here. That'd be great. Hi, Jessica.
Amazing. Thank you. Step 1, can you hear me?
Yes, we can hear you.
Amazing. Great. Step 1 done. Hi, everybody. My name is Jessica. My pronouns are she, her, and I'm a delivery manager at MadeTech, which is a public services sort of government consultancy. We go into local and central governments and the NHS too, and help build really cool, helpful stuff that helps the citizens of the UK. So that's who I am. I'd like to tell you a little bit about this project called NHS Book a Virtual Visit, how it came about, and also do a live demo, which fingers crossed goes completely fine. And hopefully we have the help of Amy in the background to make some of this happen. So I'm going to share my screen so we can see it. Here we go. You should be able to see my screen. Yeah, cool, great, awesome. So welcome to Test Ward 1. It's some great naming. I know it's my fault. This could be any hospital ward. And imagine I am a NHS staff member. So I'm potentially a nurse on a ward. I'm running around taking blood tests from people, keeping patients alive, whilst also having to whilst also having to keep families informed too. And that's the piece that is taking up a lot of time for these NHS staff members. Due to coronavirus, nobody is currently allowed to visit in hospitals, or the caveat to that is if you're the partner of someone giving birth, you're allowed to be there for the time that they give birth and then you have to leave. Or if you are in palliative care, then you are also allowed, those are the only sort of two allowances, as it were. Everybody else, so the vast majority, so 99% plus of, don't quote me on that number, but the majority of people stuck inside hospitals at the moment are not allowed to have any visitors. If you're a massive tech nerd like I am, you might go into hospital with a power brick or a charger. But if you're the majority of people who are whizzed into hospital, you don't have any of that. So you're stuck in your hospital bed. You maybe get one phone call every few days, and apart from that, your family don't really know what's going on. This is actually quite a personal story for me. A few weeks ago, I contracted coronavirus. I was reading in my back garden one day, and the next day, within 24 hours, I was in the back of an ambulance going to hospital. It was a horrible experience, but the NHS helped save my life. Whilst I was sat in the hospital bed, I wasn't able to call my family, or my family weren't able to speak with me because I was in an intensive care ward, etc. And the NHS staff members are super focused on keeping people alive, which I think we can all agree is the right thing to do. So once I got better, I came back to work, and we had an opportunity to build a solution called Book a Virtual Visit in an alpha over 2.5 days. So what you see now is a sort of continuation of this. It's been the last few weeks. This is an open source repo. I'll drop a link in the chat afterwards, but it's all here. You can see our nearly 1,000 commits and still going strong. So if you like what you see and want to help out, please feel free. So diving into a demo, and again, fingers crossed this all works properly. What we see here is we have a patient. We have Wonder Woman who hopes to talk with Superman at 3 o'clock today, which might be a really awesome call to happen. And you have Marsha P. Johnson talking with Xavier this morning. So as an NHS staff member, as a nurse on a ward, I'm able to have my iPad, which is already on a ward, and be able to walk around and very quickly book in my patients that are stuck in these hospital beds into the system, so that they're able to see and speak with their family members. So let's do that now. So we're going to say that this is Jessica, and I'm going to call Amy. I'm going to send Amy a text to the ODI number, and we're going to do it at 11:30. So again, I'm the NHS staff member in this scenario. I go through, I just plugged in all the details that I've gotten either from the patient information sheets at the end of the bed or the patient themselves, so I can check everything is correct. I can then book a virtual visit. What that will have done is that would have sent a text message via GovNotify, which is the government's standard notification system that sends or should send all text messages, emails, and letters on behalf of the government in the UK. So that will have arrived. That will say something to the effect of, you have received you've been booked in for this call that will happen on this date at around this time. Let's say in this example, I'm the NHS staff member. I'm stood over the bed of Jessica, and it's ready. I'm ready to start this call. So we go start call. There's a piece of around data management here. We didn't want this tooling or this service to kind of be bogged down by having to hold too much patient PII. So there's just a visual prompt for the NHS staff members before they hand the iPad over to check that these details are correct, that the person is the correct person to be joining the call, and we'll click attend visit. What this does is it loads up our video bridge provider. You'll see myself in a second. I think my camera's frozen because it's using it on Zoom, but you would have seen me. I maybe switch input, I'm not sure. And what this has done is it sent a second text message to the key contact with a unique URL to join. They click that link. There we go. And we see Amy. Hey, Amy. Amazing. So I'm currently stuck in my patient bed. Again, it's annoying that it's using the feed twice for Zoom, but you'll see my beautiful face here, and we're having a chat away. Once the call is finished, we go end call at the bottom, and then we hand it over to the NHS staff member. We've been user testing from day one on this, so we've not been able to get on site due to coronavirus restrictions, but we've had daily calls and hangout sessions with sort of boots on the ground nurses and doctors. And one thing we found is that when you finish this call, so you're a patient stuck in a hospital bed, you perhaps haven't seen or talked with your family in at least a few days, maybe even a few weeks. And at this point, the first thing you say when you hand the iPad back over is, "This is amazing. Can I have it again?" And so we've added functionality based on that user feedback, so that the NHS staff member is very easily able to rebook it. It defaults to the next day at the same time. They click continue, they click book visit, and then it's booked in for the next day. So if we go to here, we can see upcoming. We can see this call is booked in for them, which is pretty cool, I think. That's sort of 3/4 of the experience. There's a little piece around the admin side of it too. So if you're, this is where like the juicy data starts coming out. If you're an NHS staff member who's sort of in charge of a hospital or in charge of a trust, you might be really interested in what's actually going on inside of your hospitals. This is live data from our trust in London Northwest. So these are 5 hospitals and 1 test hospital for live, doing in the last few days over 3,000 calls. We can see the most and least here. Within the hospitals themselves, you can see the number of wards that they have. So we can see here Northwick Clark Hospital, which is actually my local hospital in Northwest London, is doing 2,500 booked visits. We can view these here and see everything about them. So we can see all the list of the wards and how well they're doing. We're also working to surface other data too, such as like the average time of calls, so tracking how long these calls actually happen for. Anecdotally, we've heard from our user testing sessions that these calls typically go on for about 4 hours, which seems like a really long time, but if you put yourself in the shoes of someone who loves their family and is stuck in a hospital bed and hasn't seen anyone, actually 3 or 4 hours seems like an appropriate amount of conversation time. Yeah, so that's the NHS Book of Virtual Visit tooling that we've built. Quick plug for our open source repository. It's MIT licensed. The README is completely up to date, so you should be able to get set up quickly. The only paid solution we have here currently is Whereby, which we're using as a video bridge, but we've also got it working with Jitsi, which is another free open source project as a video bridge, or could work with something like Zoom or Hangouts or Microsoft Teams. We see this as a use case that could be very helpful for a bunch of different government departments for things outside of the NHS, for example, within care homes, so people not wanting to visit there. But yeah, I'm going to pause there for any questions.
Fantastic. I think there's a lot of people in the chat saying what fantastic work this is. It's great, and it's exactly what Open Data Saves Lives is about. It's not just about open data, it's about open source and open approaches. So could you just help people understand this, what MadeTech do and what you want to do with this next? Because
Great
it's
question.
a project, so you're maintaining it, but you don't own it, do you?
That's correct. It's sort of so in terms of ownership and licenses, it's under MIT, so anyone can sort of take it and go do some really amazing, lovely stuff with it. And we've done that on purpose because we hope that there are some really awesome people on this call who might want to help out with that. In terms of what we're doing with it next, we're rolling out to other trusts who have reached out and who are interested. The NHS is an interesting space where some NHS trusts have a lot of sort of on-site technical support available, so that they have their own developers, for example, whereas other trusts don't. So we have a real mixture of different NHS trusts across the UK who have reached out saying, you know, we're really quite digitally mature. Can we just use the library? And we've said, yeah, go for it. Like, here's an email that you can email if you have any questions. And we have other NHS trusts who are interested in rolling this out, but perhaps not as digitally mature or have less hands-on boots on the ground, and in which case MadeTech support that over a rollout time of about 2 weeks.
Cool. So it takes 2 weeks to deploy. The code's all there.
Yeah.
You don't need to pay anybody to do it. If they wanted to take some advice from MadeTech, they could and pay to do that. But that's it. So any trust in the country could do it. Any care home could have this if they had some support. So it's fantastic work. It's exactly what we want to talk about, and we'll be adding it to the Open Data Saves Lives library, and we'll be shouting about it. And I think this really demonstrates what this is about. The reason why MadeTech are on the call is that I ended up on a Twitter conversation with Luke from MadeTech, who's in Manchester, who'd been working with FutureGov, who are one of the sponsors of ODI Leeds. And it's one big, it's a great story of how people are working to fix problems and then sharing it openly to get the most value out of it. So thanks very much, Jessica. And I guess we're going to put a little, Amy will be in touch to put a 200-word blog post on our Open Data Saves Live website with a demo, and we'll be sharing that as widely as possible. So, and then we'll put some contacts on so that people can find the repo and work with it. And we talk about having 3 things for our projects. It's all you need is to have a story blog about why we did it, a technical blog of how we did it, and then a repo with the code and data if possible. So this is a great story. And what I love about this is nowhere is there a specification, nowhere is there a report talking about a need, nowhere is there a cost-benefit analysis or a return on investment business case. We are fixing a problem, we've done it out loud, and some people have found some way to help MadeTech build it, and then we're sharing it openly. It's a massive challenge to the way in which stuff is procured in the NHS, and I would love to smash it open with a load more stuff like this. So,
can I ask a quick question? Is that okay?
Yeah, you are Corona Y on Zoom.
I'm Tyler, but I'm one of the community managers for Corona Y, which is it's a volunteer force, international force dealing with data problems in the COVID space, using basically helping researchers. I'm just curious about, because my work is international. I work with people all over the world developing things. Have you thought about how you could expand this can it be edited and changeable easily into an international markets and international hospitals? Because I've got access to like New York hospitals and LA hospitals and Canadian hospital people and people who are researchers and connected to that. And this is, again, it's a human tool for humans who are actually just going through human problems. And I'm not, obviously some of them might already have solutions, but if it can, where Corona Y is pretty much built on entirely open source technology, just about, we use Zoom here and there, and we've got a few other technologies that are not open source, but we're pushing towards as much open source as possible. And yeah, I just think that's a really interesting, a quick solution that seems to really work, and it is answering. Again, Corona Y is all about just solving problems and working out how to do it, and it seems you just really manifested that. So I'd love to have a conversation and maybe break out, because we've got like 1,000 people, developers sometimes who are not busy. So if I can find spare developers who are interested in solving problems, who are not busy on something else, I'll see if I can send them your ways as well.
That'd be really cool. To answer your question really quickly, to help keep us on time, so that Paul doesn't get angry with me. To answer your question, Corona Y, yes, this can be taken by anyone to solve almost any problem where one human wants to connect with another human, facilitated by an intermediary. So in this example, we've seen that there are, and I've personally witnessed being inside of a hospital and not being able to talk with family and loved ones, and having a nurse or an NHS staff member being able to facilitate that. But there could be X number of other ones. For example, the probation service, for example, things like job centres, etc. Sort of going to a physical location to have a conversation with someone feels a bit antiquated, and also feels quite risky during coronavirus. So to answer your question, yes, it can be taken. Please feel free, reach out to us on Twitter or something. All content at the moment is static, so it would just need some translations if it wasn't that. We are aware of large, usually American corporations, who are offering quite horrific contracts to NHS trusts across the UK to do a similar thing, and I'm a big fan of avoiding price gouging and giving the NHS more money to spend in sensible ways.
Fantastic. And it's under an MIT license, so it's all there, so it's completely transferable. Great.
Yep.
Fab.
Thanks.
I think there's a round of applause. We're all giving that a round of applause on the call, so that's great. And we'd love to help you take that forward and do that. Yeah, look at that, fantastic. So next up is Beautiful Info. Marc or Paul are going to do a chat, and over to you.
Thanks, Paul. This is like a Corona survivors group, isn't it, with Jessica and you and I and others on. So it's a great support group. Hi everyone, I think you can hear me, and I'll share my screen in a moment. What I'm going to show you just very briefly, it follows a point we had on one of these webinars a couple of weeks ago where everyone was talking about lots of geographical data and that being a problem, and Paul having a really good network of people who can sort out gazetteers and how postal geographies don't match with council boundaries and all sorts of things. And I kind of just made a comment that that's really, really important. But the other thing that's really important for us as an acute hospital is the geography within inside a building. So, you know, as Jessica will probably have realised, that hospitals are quite dangerous places to be, unfortunately. So you might go there with COVID, but you might catch COVID when you get there as well. You know, with best intentions from everyone. So we've been doing some work looking geographically inside a building, which I'm just going to try and share my screen. So you should have my Google browser. Have a yes or a thumbs up. Yeah, okay, thanks, Patrick. So I'll just show you a couple of things we're looking at, and I'll quickly refresh a couple of things that we did. So we internally we've sort of moved some services around. Do you get my PowerPoint as well? Have you got my PowerPoint? Yeah, okay. Oh, sorry, bear with me. So one of the issues that we've had is we had to kind of quickly move some services around, and we did kind of very traditional kind of graphing, just showing kind of where we had nosocomial infection. So KNC is a hospital at Canterbury, the Kent and Canterbury, and we tracked our nosocomial infections, and we did this kind of traditional, well, this is where we found some cases, we then found some more here, and so on, and kind of stuff that people would be used to. And we looked at when we moved some services very quickly and tactically between sites, and we did a kind of traditional, you know, what do people think? And it was very kind of labour intensive and talking to lots of people. And then what we thought we would do is kind of get to here, which we'd actually started designing for other things. So you've got my Google browser again?
Yeah. Okay.
Thank you, Corona Y. Good nodding. And there's two kind of aspects to it here. So one at a very simple level, we have we're a big hospital, 6th biggest hospital in the country, and lots of people turn up with letters. You know, who sends letters anymore? But they turn up with letters because they've got an outpatient appointment or a diagnostic test or something like that. And these are big, kind of unwieldy buildings. And as some people said to me a while ago, hospitals, and this screen kind of exemplifies it, hospitals look like someone's gone up in a helicopter with Lego and thrown it out the window. And why would you know your way around a hospital? So what we thought we would do is to drop a link, a web link, into a letter or a text or via an app that we provide for patients so they can actually see where they're going. So at its very simplest level, we just worked with a local university and got a student to map geographically all the vectors so that we can draw different parts of the hospital. So at least they know from where to park their car, kind of how to get to the hospital. So they would get this type of thing in their letter and actually know where to park their car and the big building to head for. What we then did, we start to develop that and say, well, you might turn up in a certain place. I hope this is sort of all rendering okay. So you might turn up at the A&E department, and you might need to get to the stroke ward, which is Richard Stevens. So we'll pick that here for them, and we just show them simply, and we can track them as they're going. If I was on site, I could have this on my phone, and it would be like an internal sat nav for the hospital. And I can put the toilets on there. If they were there all day, I can show them where the restaurant was. Just kind of really obvious things. And to a group of people on this call, this look really straightforward, but this is quite a big deal for patients of ours. And without sort of wishing to patronise them, because I've done it myself and followed some around, we get a lot of people who turn up with those outpatient letters who can't read. So across the kind of area, the constituency that we cover across East Kent, we've got some of the most deprived wards in the country. And we have people who are walking around with the letter knowing that someone like me will come up to them and realise they probably are lost and kind of guide them through. But we found that by presenting it in a way that people would be used to on a kind of smartphone, like a kind of sat nav, they can do some of that themselves. So, so there's a very sort of administrative function to this type of thing. What we're looking at the moment is whether we can track outbreak better than we would have obviously previously been used to. So we've got quite good data on where our patients are, but we haven't got very good data as the NHS on where our staff are, or where each of the renal dialysis machines is, or where each of the drug charts are within the hospital. So we're kind of talking through beautiful information to some kind of IoT providers, looking at Bluetooth technology and, sort of barcoding people having wristbands on so that we can track if they've gone through a door, all kinds of things. And Paul's on the call. Paul's going to put a link in the chat about a webinar that we're going to run on this next week as well, actually. So my main point I wanted to get across was that for all that we've talked about geography, and that's all great and all groovy, the geography of the building is really, really, really important at the moment when we're trying to track outbreak and and design staff rotas and cleaning rotas and all sorts of things. Was it the cleaner who was asymptomatic who worked across those two wards that created the problem that we had? So that's kind of that. How am I for time, Paul? Have I got another minute or so?
Yeah, go for it.
Okay. The other couple of other things I just wanted to mention very briefly. So that's some work we've done kind of inside, which we can share how we did that. We just worked with a local university. I think there's a role for hospitals, kind of as Jessica was alluding to, where us, industry and universities and the open source community should work much, much better together, because we've got a million research questions the whole time. If you want to do a PhD, just walk towards a hospital. So I'm trying to create really good relationships with the local universities, because they're good for literature reviews, young bright students, all of that. And this example has worked really well. Someone could write this up. You're then into kind of more traditional measures of COVID that we've done with things like Power BI, which again, we can share how we did this. This is a kind of different level. This is something we're playing with at the moment. This is plotting our COVID cases by geography. Just give it a moment to render. We dropped care homes on here, all kinds of things, but kind of live plotting of nosocomial data, right through to kind of dashboard type data like this, which you could kind of render on a phone very easily, looking at how many COVID patients we've got in blue, how many in red, how many suspected cases we've got, which is these whites with a blue outer ring across each of our sites. We're looking at data which we wouldn't historically know much about. How much oxygen do we think we need? So as a lot of you know, a few months ago, the race was on to build ITUs and ventilators, and with the best intention, that wasn't the right direction to head in. But we had to learn really quickly all about how to measure oxygen data and flow and capacity and so on. And then basically looking down into each of our areas about how many patients we've got on each ITU, how many beds we've got coming up later, and so on. And the last thing I wanted to mention very briefly, just because I think it's quite interesting and quite controversial, is we are also, and this kind of reflects my academic background, I'm really interested in ethnicity and the whole thing around BAME. We're trying to kind of get rid of that term because it's not particularly helpful and it's not particularly meaningful. So we're working with an organisation that look at people's forename and surname and allocate characteristics and kind of odds ratios of characteristics to those. So this is some anonymised patient data for you. And I'm really interested in, are there variations, most of all in risk. So are certain members of our staff at greater risk of COVID, and do we need to draw them back from certain services? And then potentially, are there certain groups that have a role by accident or deliberately in spreading it? So have we got certain ethnicities that always tend to fulfill certain roles, and do they worry in a different way to other ethnic groups? Do they inadvertently spread because of their movement and their social interactions between different groups? So we're doing something, and this kind of links back to a point Paul was making, where the IG is quite sensitive around some of these things. I think we, as part of Open Data Saves Lives, we want to put up a strong case to say, let's start with best intentions and let's start from yes instead of no, if you like. Let's not start from a kind of vague privacy concern argument, but start from a principle of, if there are certain ethnic groups at greater risk, let's get through the IG more quickly than we had historically, and actually start linking and proving some of this stuff. So I'll stop there. I think the contribution today, Paul, was, as from a couple of weeks ago, is to look at geography insider building. If that's the only thing people take away, that's powerful. And we're kind of interested in sharing how we've done this and taking other people's ideas about how useful this is. But we're also, as Paul and I know, we're kind of really interested in pushing the argument on the IG with some help from ODI HQ as well, as Paul was kind of alluding to. I'll stop there, I think, Paul.
Thanks very much. It's great. And I think the other part of this is these tools are being built by one hospital in Kent. They're fabulous. They're the cutting edge of what's going on in terms of data and IG in a hospital. The next step is how we start and address the whole procurement issues around these sort of tools, and could people in a hospital up in Carlisle deploy exactly the same thing in what they're doing, and how do we help NHSX and NHS Digital be more of the web rather than bureaucratic, using systems to suit themselves rather than what we need to do to fix problems. So thanks very much, Mark. And it's really good to get things grounded in real problems that are being fixed every day. So again, I guess we'll be in touch with Paul Clark to get some of this stuff on the Open Data Saves Lives webpage, get some screenshots and share some of that. And then also start to talk about how we create a repo of these tools that can be deployed and scaled across the system. Cool. So someone just asked, there's some questions in the chat. One chat was about, was ODI Leeds and HQ at the geospatial launch on this week? If you follow Lee Dodds and Jenny Tennyson's Twitter feed, it's very polite commentary, but you can tell that they're furious. So it's they're quietly furious by the lack of progress from the Geospatial Commission. So if you have a look at that, mine and Tom Forth's Twitter feed might not be as polite in our commentary on what's going on. So I think there's a lot to do around geospatial data and how it is slightly cocked up in the UK, and how we keep shooting ourselves in the foot with especially addresses, how we got ourselves in that tangle. We're at 11:48, so we're still under the hour. We've got 12 minutes. Has anyone got anything passionate to say or do, or also are there things people would like to talk about in the future that we can include in the Open Data Saves Lives work? I did a bit of a shout out for our Northern Lands conference. We've got a full 2-hour session on Open Data Saves Lives during that session, and I'm quite excited to say that we've got Ben Goldacre talking to us. I'm hoping he's going to talk about the project he's been working on, but you never know with Ben. It might end up in a whole different place on the conversation. So we're really looking forward to that. We're hopefully going to have some people from NHSX and NHS Digital talking about open data and how they're doing that, and we'll be asking them some questions there. So please look out for the Northern Lands and the full 2-hour sessions about what's going on in the UK, but also in the Netherlands, about how they're dealing with data and health. So that's going to be a really good side casting or side view of what's going on, which will be great for everyone. So would anyone like to make any points? Anyone else got anything else to say?
I just want to get in touch with Jessica and other people on here, but we can do that through Twitter or email or something, as long as we all put contact details on the page. That'd be good.
So we'll be taking a record of the chat and sticking it in the Google Doc that's on our webpage, the Open Data Saves Live stuff. So yeah, that's part of the. I think a lot of people are going to be in touch with Jessica about how we deploy that fantastic tool.
Yeah, definitely.
Yeah, which is fab. And I think that in terms of Dave, ODI HQ, the tools and guidance you're building, that is all open on the web. But I think we just need to do a bit more comms with you to help get that out as far and wide as possible. So we'll be in touch with that as well. Cool. Right, everyone, it's 11:50. Perfect. You've got 10 minutes to make a cup of tea before your next video call, if you're me. So yeah, or maybe a fish finger sandwich. Right, great stuff. See you, everyone.